Hello everybody, my name is Dr. Sarah Perkins and today I'll be presenting on behalf of the Vaticuti Urology Institute in regards to our research about external validity of the Stephenson Nomogram predicting the outcomes of prostate cancer patients treated with salvage radiotherapy after radical prostatectomy, the importance of genomic data. Of men undergoing radical prostatectomy for prostate cancer, some will present with what's called adverse pathological features, meaning they have features of aggressive disease in the form of extra prostatic extension, higher Gleason score, or presence of positive surgical margins. Now, greater than 50% of these men will experience biochemical recurrence, meaning they have a rise in their PSA after they receive surgery. Many of them will be offered salvage radiation therapy for treatment. One of the most commonly used tools to predict the oncological outcomes of such individuals is the updated Stephenson Nomogram. This was originally published 10 years ago with research out of the Cleveland Clinic. They look at oncologist outcomes in terms of metastasis and survival for men who undergo radiation therapy. This study was based off of clinical data, not genomic data, and no external validation was performed when it was originally published. They validated it using their own data set. This is the updated Stephenson Nomogram, which was published in 2016 out of JACO. As you can see, the Stephenson Nomogram takes into account a bunch of different patient factors, including whether or not they received hormone therapy, their PSA before salvage radiation therapy, or the dose of radiation that they received. From this, they extrapolate a score and can predict a 5 or 10-year biochemically recurrent-free rate for you. Now, our goal was to externally validate the updated Stephenson Nomogram utilizing different Decipher genomic risk profiles. Decipher is a genomic test for prostate cancer that looks at 22 mRNA biomarkers and assigns user scores based on that, giving them a low, intermediate, or high risk score. Our cohort included patients undergoing salvage radiation therapy for biochemically recurrent prostate cancer, status post radical prostatectomy. Biochemical recurrence was defined as a PSA greater than 0.2 nanograms per milliliter. Our data was collected at 6 different academic centers across the United States between the years of 1990 to 2010. We looked at all available demographic, pathological, and oncological outcomes for these men, and they were compared across different Decipher risk profiles, low, intermediate, and high. The Stephenson Nomogram was then externally validated using measures of C-index and calibration curves. Our endpoint was the same endpoint as the updated Stephenson Nomogram, which was 5-year biochemical recurrent-free survival rate. Median age of our cohort was 60 years old. The median pre-salvage radiation therapy PSA was 0.43, and the median Decipher score was also 0.43. 86% of our patients had a pathological Gleason score greater than 7. 78% had greater than PT3A disease, meaning that it extended outside of the prostate, and 78% had positive surgical margins. The proportion of patients with low Decipher score profile was 52%, intermediate was 28%, and high risk was 19%. The median pre-salvage radiation therapy PSA in these groups increased with respective increase in Decipher profile risk, which we would expect. The median follow-up time in our study was about 6 years. This top graph represents the biochemical recurrence-free survival curve. At 5 years, 52% of patients did not have biochemical reoccurrence, whereas at 10 years it was only 33% of patients. That means about 2/3 of patients would have failed treatment at 10 years from surgery by having biochemical reoccurrence. This bottom graph is stratified based on the Decipher risk profile scores. The low risk profile is represented in green, intermediate in red, and high risk profiles in blue. As you can see, with higher Decipher risk profile, there's a significant increase in higher risk for biochemical recurrence. In regards to the biochemical recurrence-free area under the curve for the Stephenson Nomogram, the intermediate and the low risk profiles were no more predictive than a flip of a coin, whereas The area under the curve was significantly improved with high-risk Decipher profile. We also performed calibration curves which showed improvement with increased risk profiles. Our results show that the performance of the widely used Stephenson nomogram was dependent on the Decipher risk profile score with superior accuracy in patients with higher genomic risk scores. In conclusion, we were specifically interested in externally validating the updated Stephenson nomogram utilizing genomic data. We measured utilizing C-index and calibration curves. We achieved our goal as the Stephenson nomogram was shown to be dependent on genomic risk profiles. This is very relevant as it gives physicians and patients an opportunity to discuss treatment options with more nuance and consideration of their prostate cancer genomic profile. And this is extremely timely as Decipher risk scores based off of genomic data is relatively new in urology. Thank you.